tell us about the company
Sure.
and what you guys do, just so the audience is with us.
Yeah, sure. So the company is called Prenuvo. We do a clinical diagnostic quality screening MRI exam. So we bring patients in to our own clinics. We have, and I can talk a little bit more about the technology, but we have this machine and imaging protocols and radiologists that we collect images for about an hour, and we look at every single organ of the body, and we give you a very detailed report that goes organ by organ, condition by condition. If we see something, what is it? What did we see? And most importantly, what should you do about it? So it's something like a 500-point checkup for your body, the same way you might get a checkup for your car.
Yeah, I actually did the scan. I am a big fan of the All In podcast. And I was listening all last year, and then I heard them mention it, I think once in November, and then I heard them mention it again in December. And I believe it was Chamath, who was one of the early team members of Facebook, and he's a billionaire, and he had told a few of his friends to do it. And I don't know if they have any formal affiliation with the company or not, or they were just sort of mentioning it.
And he's not an investor either.
Yeah, he's not an investor. They're just
excited
fans
about what we do.
Yeah. So they're fans. And the recommendation came, authentic. They talk about stuff on their podcast they like. I was like, oh, you know what? I'm always interested. I'm always getting different scans done. And I come and I share with my audience. I share with them, hey, look, I did the scan. Here's what I saw, other things. Not that my results is going to be your results, but more just, I want to see more health transparency, and people can know what the options are that are out there. And generally, whether it's good or bad, I like to just share my information that's there. So we'll go over my scan results. Like I will talk about my scan results, and I already gone over it with my doctors and other stuff. And we can talk about some of the things that showed up in there, and we'll share the screen for those that are watching on YouTube. And if you're listening on audio, you can click on it later on if you want to see some of the imaging that's there.
No, that'd be great. And really, what would be helpful in going through that really is to demonstrate one of the core philosophies of Prenuvo, which is we want to empower patients with knowledge and recommended actions so they can really take control of their health.
Yeah.
And I think coming out of COVID in particular, we're all statistically a little bit less healthy. We have missed many of our preventive health checkups. And I think there's, whether or not we feel this to be justified or not, there's, I think, a feeling that the health system may not necessarily be looking after our sort of health needs.
The health system is reactive, and how do we go from reactive to maybe being more proactive?
And so people, we see this, we see just tremendous enthusiasm for getting ahead of our health issues and for focusing on preventive health. And I think that's really healthy for the individual, and I think it's healthy for the system as well.
Yeah. Have you been following at all some of the work of Peter Attia and his new book?
Yes,
Outlive.
absolutely. Yeah.
One of the core concepts in Peter Attia's book, for the audience that may not be familiar, we've written a little bit about it and recommended the book to people, is this whole chapter that he has about cancer.
Mm-hmm.
And in cancer in particular, the statistics are crazy. I don't have them in front of me. But just by discovering cancer earlier for individuals that have it, our rates of survival increase exponentially. It's kind of nuts, pretty much across the board. If you can find a cancer earlier, even without sort of the whole seed and soil theory of cancer that a few people like Jason Fung have come on this podcast about, and they really recommend, getting in control of your metabolic health. My mom was diagnosed with cancer probably about 10 years ago. And the way that she found out that she had breast cancer is what happened to a lot of women. She was in the shower one day, she's, washing herself, and she felt a little lump.
Yeah.
And she went in, and when she went in, it was diagnosed at the time as like a stage 2 cancer. And we unfortunately are this place where, even though it's America and we have all this great technology, that's how a lot of people find out about, in particular, breast cancer, or they start to notice that something in case of another cancer is not working well in their body. They're having pain, they're having pressure on something, they feel something in their abdomen, they don't know what's going on. They're going in for a regular colonoscopy because maybe they have some blood in the stool and they see, oh, they have colon cancer. It's very sort of reactionary in our cancer approach.
I mean,
and the last thing I'll tie in before I tee it up for you, one of the reasons I got excited about Prenuvo is after I did my scan, there's a few celebrities that we're connected to in our podcast and our medical clinic that were really championing that they felt, not that people go there just to get scanned to see if they have cancer. It's really preventative for all categories, But the ones that I felt that were being most vocal and sharing with the rest of the audience was they felt super excited about this scan helping them detect cancer years ahead, maybe even decades ahead of when they would have naturally found out about it. Any thoughts on that?
Yeah, no, I mean, there's such great stories to hear and help build awareness about what we're doing. Maybe just to jump in with a few stats first. So one of the unfortunate things about our healthcare system is we don't have that much preventive screening tests for cancer. And in fact, only 14% of cancers are caught during a routine preventative screening exam. So this would be mammogram, potentially PSA test for men, and lung cancer screening for people that meet essentially a definition of a certain number of pack years of smoking. And the other 86% of cancers are caught either incidentally or they're caught at a time when a patient presents with symptoms. And we know that oftentimes that can be when cancer is quite advanced. The average cancer is caught at late stage 2, early stage 3. And the difference between catching all those cancers at stage 1 and the average stage of diagnosis is something like 3 to 7 times better survival.
Wow.
And then even when patients present with symptoms of cancer, our health system takes oftentimes quite some time to diagnose them. So there was a study in the UK where, in fact, 50% of patients who were diagnosed with cancer were diagnosed in an acute setting, so in hospital when they presented with acute symptoms. But also in the UK, the average cancer from the time of symptoms presenting to being diagnosed is something like 6 months. So as Dr. Attia says, cancer is really a race against time. The higher the cancer load is in the body, the more difficult it is to treat it effectively. So the earlier you catch it, the better. And what Prenuvo offers is a possibility to really diagnose cancer in patients that are still asymptomatic and therefore very early.
How early? Like, let's take, for instance, breast cancer, right? And with this full body MRI scan that you guys have and the whole AI technology behind it, what's the earliest cancer that can be detected?
Sure. We typically can find cancer that's around 1 centimeter or greater. So that's 10 millimeters. That's not to say that we haven't diagnosed lesions that are very concerning, smaller than that, but also they become very difficult to biopsy, smaller than 10 millimeters. And oftentimes you can miss the lesion on the biopsy and therefore not be able to really identify one way or the other what it is that we're seeing. So it's about 10 millimeters everywhere in the body. For men, we do a detailed prostate MRI. So there we can see things a little bit smaller. But 1 centimeter might sound big to some of your audience, or might sound small, or might not be understandable because we're talking about centimeters and not inches. But it's still relatively early in the life cycle of a cancer.
Is that generally, that won't even be in most people, that's going to be probably either stage 0 or stage 1, right?
Correct. It would be stage 1. It would be cancer still localized to the organ of origin. And that represents the vast majority of cancers that we're diagnosing.
Yeah, that's huge.
And it also really represents just the way cancer grows. So cancer grows obviously geometrically. So it starts with 1 cell and then 2 and then 4 and then 8 and so on. But also cancer has to acquire a certain set of mutations to sort of proceed to the next stage. So we can spend quite some time at an early stage. In fact, if the average pancreatic cancer, there was a study at Hopkins a few years ago where they looked at the average age of a pancreatic cancer at the time of death of the patient. And they were able to age these cancers as being somewhere between, I think, 7 or 8 years. And when we are seeing pancreatic cancer at Prenuvo, the vast majority of those diagnoses are still confined to the organ of origin so early. And it sort of makes sense that in the 7-year lifespan of a cancer, there's probably a couple of years where it's too small even for us to see. And then there's 2 or 3 years where we can still diagnose it at a very localized stage. And then it starts to sort of run away towards the end of its life.
Yeah. Well, I want to complete the story with my mom. You know, she's doing great. It's been 10, 13 years. I can't do the math right now. And she's been fantastic. She worked with a really incredible doctor, had a whole team of individuals who were helping her. And a big part of that was, we've done some episodes on this before, but, some practitioners using therapeutic approaches like the ketogenic diet, and then significantly lowering carbohydrates in addition to all the other stuff that was there. There was plenty of things. I'm not by any means telling people that have breast cancer that it was that simple. There was a lot of stuff that she was doing. And and a lot of root issues, including kind of looking at some dental health items that might be connected to her situation, but she's doing great and she's cancer free.
That's great.
Yeah, but I wished I would have had that. I'm always transparent with my audience. I did your scan before, I ever had somebody from your team reach out and say, hey, would you like to have a conversation about our technology and everything? But then you guys were really kind. I said, hey, listen, I've already paid for my scan. Don't worry about giving me a free one. I've already done it and I don't feel like the need to do it again so soon. And they were like, okay, well, what about giving it to somebody else? And I was bringing it up with my mother-in-law, Nilufar. And I was like, hey, do you want to do this scan? I typically don't accept things, from people for the audience, for like potential guests. But she was really excited and she went and did her scan and she had a chat with your team and everything. So thank you for that, of course.
No worries.
And there was a couple things that she had to pay attention to on her area, but largely it gave her kind of a sense of peace of mind. I'm sure you hear that from a lot of people that go in and do your scan.
Yeah, no, I think often people will come in worried that we might find something that is life-threatening. And of course, when we do, that's a potentially life-saving diagnosis. But also, all of us have some degree of worry about our health. When we have headaches, we have abdominal pain that comes and goes. There's always that little voice potentially that is asking, well, what might this be? And I think just having that clarity and peace of mind is such a priceless thing. And particularly for patients that might have had cancer and they're worried about it coming back, or for people that might have a strong family history of cancer or aneurysm or disease, and just being able to, for those people, not being screened in some ways is affecting their quality of life.
Yeah. So just to set the stage a little bit more, I did my scan in January of this year. I think it was I got my results back on January 27th. You have 8 clinics around the US right now, and you're probably going to be opening up more soon, I imagine. So I'm here in Los Angeles. So there's one literally down the street over here in Wilshire. What are some other cities that you guys are in right now?
So we started in Vancouver, Canada. So we screen patients there. Then we are open in Silicon Valley, in Los Angeles, in Dallas, in Boca Raton, so Southern Florida, New York, Chicago, and we'll be opening another 3 or 4 locations this year. Yeah.
So you basically make an appointment, right? I think you guys gave us a discount code our audience can, use, and it's not an affiliate link or anything like that. There's no compensation. Just if people want to do it, great. You get a little discount. We'll include that inside of the show notes, mention at the end. So let's say you book it. You go to the center during your appointment. The clinics are really nicely set up. They look more like a hotel lobby than they do like a doctor's office, which is always nice because there's a lot of people that are always worried. They get the anxiety, going to the hospital and sort of that very clinical white lights, everything like that. It kind of sets the stage for kind of inducing anxiety. So it's a very chill setting.
Yeah.
You go to you chill in the waiting room. They call you when they're ready. They were always on time for all my friends. I've had a buddy of mine that did it as well too, around the same time that I did it, just because he was curious. And then you get put into sort of a changing room that you have. You change into like a typical sort of, what do they call it? Like nightgowns or whatever it is.
It's a comfortable gown.
A comfortable
enough
gown.
That some people want to purchase them when they leave.
Okay.
For pajamas.
And then you go to the MRI room. And in the case of the Los Angeles, there's a few different rooms that are there. And what was really cool is that basically, the techs are all nice. They let you choose a movie on Netflix, or you can listen to a podcast on Spotify. Hopefully you guys want to listen to my podcast when you're there, but I won't be hurt if you pick a documentary on Netflix or something. And then actually you are there for an hour in this full body MRI, and you kind of are just like watching a movie. And then every so often your techs there give you sort of instructions like, hey, you're going to hold your breath for about 5 seconds so they can really get a scan on a particular area. And the whole thing takes about an hour. Yeah. Is that generally the basic experience?
That's the general experience. And I would sort of double click on the sort of spa-like and welcoming environment, because we found just so critically important that patients really do have a negative connotation with healthcare, because our whole concept of disease is based on this idea that we diagnose things late, and therefore, if we're looking for anything, it's always going to be serious. And so anything that reminds people of this, like you said, white walls, or you won't find a white wall in one of our facilities. Our staff are very, very focused on making patients feel comfortable. And that's important because some patients might feel a little claustrophobic or a little anxious. For us, really, it all can be summed up by the fact that you are in some ways our customer. And in most imaging settings, the insurance company is the customer. And that means that we want to make sure that you feel comfortable and supported in this journey to better health.
What is the test the best at looking at? And then also where are their limitations? No one test, as many clinicians on our podcast have talked about, we're not at the level yet where we're living in the Star Trek, age where you can literally go to one scan and you find out everything in your body.
Yeah.
Right. So every test has things that it's great at, and every test is going to have limitations. So tell us about, what is a test good at looking at? What are the most common things where it really feels like there's actionable items that are related to where your health is for people who are wondering like, hey, am I really healthy? And then where are the genuine limitations? Because we like to be honest with our audience and share them like, hey, great. Like you may not know about this or that, but you'll still know about these things, which could make it worthwhile to do.
Sure. Well, the best way to think about this is there's sort of two screening modalities that have historically been used for whole body. And the first one is CT. And CT is an X-ray essentially that spins around your body. So you can take a three-dimensional picture by taking hundreds of little X-rays. And then there's MRI. CT actually was a technology that a couple of companies deployed in shopping malls 20 or 30 years ago, and you could go there and get a whole body scan using a CT machine. And the problem with CT was that it didn't image soft tissue very well. It's, as an X-ray, it's very good at bones. It's very good at imaging calcium in the body, but it's not very good at soft tissue. And a lot of the concern, in fact, that physicians have about screening in general really is rooted in this phase 20 years ago where people were doing this with CT machines. MRI is it's an imaging modality that does involve radiation. We use magnetic waves to look inside your body, and it's very, very good at soft tissue. And that means that it's very good at identifying physiological conditions that we might see in almost any organ of the body. There's one exception, which is the heart. And the heart really is, you can take beautiful images with MRI, but it just takes a long time. And the reason for that is that your heart is always beating and you're always breathing. So there's a couple of things that we have to gate for. And so we, at the moment, as a company, don't do detailed imaging of the heart. That's the main limitation. Whereas CT actually is quite good at this because if you're looking for any blockage of the arteries, you're essentially looking for calcification. And calcium being the same thing that bones are made of, CT being a spinning X-ray is very good at detecting. And so that's the primary limitation of the screening that we do. But one final caveat would be that this is an adjunct technology. So we don't recommend that people not do their routine screening.
Yeah, you still need your normal lab work and other stuff that you're working on with your doctor.
Correct.
This is a bonus thing.
And tests so we still recommend that women continue to get mammograms, that we continue to do colonoscopies. That doesn't mean that we obviously don't see breast cancer or that we're unable to diagnose cancer of the bowel. But certainly for anything that a physician can see with their own eyes, for example, through a scope, it's always going to be more accurate than any type of imaging.
There's obviously the mammogram topic is a very debated one, and it's the recommendations have shifted over the years. And I know you're the CEO of a company, so you may not be able to comment or whatnot, but I got to ask the question anyway. Is this scan better than getting a mammogram? Like, not that you're telling people not to get it, but is it better than getting a mammogram? Like, can you detect cancers earlier than typically a mammogram would? Or is that based on sort of who is the person interpreting the data?
I think it really depends. I for sure would not answer that question yes. It depends on the patient and also depends on stage of life. So for postmenopausal women, when women go through menopause, what happens is glandular tissue in the breasts, this is the milk-producing tissue, starts to convolute and turn into fatty tissue. And mammogram is very, very good at seeing through fatty tissue and seeing lesions in postmenopausal women. The problem is for women that are still premenopausal or going through menopause, there's still a lot of glandular tissue there. And it's quite difficult with mammogram to see through that tissue. Yeah. And so increasingly today, in fact, in a number of states, women that are premenopausal now are able to get what's called a breast MRI. And that tends to be a with or without contrast technique. And I can describe this in a little bit more detail if you like. But Prenuvo or a contrast MRI or even ultrasound is, I think, more and more being seen as a good adjunct to mammogram for women that are still premenopausal.
Yeah, I guess the question that I've always just had, and we have a physician at our clinic, Dr. Liz Boehm, who is always discussing the nuance of this with the patients. She's a she's a cancer survivor herself, not breast cancer, and she's a nutritionist and MD and trained in functional medicine. And obviously, people have to weigh their pros and cons with the physician. But the anecdotal component that I've always had is that I feel like I've heard of multiple stories of women above the age of 40 who get their regular mammograms, but then they were the first to detect the cancer in themselves just through being in the shower and kind of seeing it. So I'm like, if you're getting your normal mammograms, but then you found your cancer first yourself, or the tumor, right? Like, is the mammogram doing its job? And I'm not asking you to comment on that, but that's just an anecdotal thing that I've dealt with in my own life and with my own mom.
I think it's just a very, unfortunately, difficult part of the body to image. And if you actually go back and read the US Preventive Task Force recommendations around mammogram, where they recommend that they be performed, I believe, every 2 years for women over the age of 45. If you read why 45 was the cutoff, it has nothing to do with incidence of cancer, and it has a lot to do with just that there are a lot of false positives and false negatives with mammogram for younger women because of this dense glandular tissue. And that's why you end up with either mammogram identifying lesions and biopsying, and only 1 in 5 lesions actually is cancer. And you also have the opposite happening, which is in there being a lesion in that dense tissue that's really hard to see. And again, that's why I think a lot of women now, particularly women that have a high risk, are starting to use more than one technique, and that provides an opportunity to triangulate.
Yeah, and then there's also the pros and cons of radiation, right? That people have to weigh out and think about, which I know my audience is obviously very concerned about. But sometimes you need radiation to get really good results. When it comes to the heart, I had my cardiologist on the podcast, and he went through my latest metabolic labs. I have familial hypercholesterolemia. My ApoB was really high. I was walking through some of the decisions that I was making with him of whether or not I get treatment. He's going to be back on the podcast. We're going to talk about that. But one of the best things is, because I come from a South Asian background, Indian, which in America has one of the highest risk of cardiovascular disease out of any ethnic minority. He turned me on to, you mentioned CT. Traditional CTs are not great at looking at soft plaque. They only look at hard plaque.
Correct.
So he put me onto a scan that we walk people through. It's called the Clearly scan. And it gave me a lot of peace of mind, not too different than doing, Prenuvo, that I, in my instance, actually had the best score that he had seen for any 40-year-old male. He had seen women that had less soft plaque, but I had the tiniest amount of soft plaque that was there. So, that was radiation. It was contrast and everything. But that type of scan, especially because I had been hearing sort of multiple different things from different practitioners, somebody saying, oh, your cholesterol is so high, you need to go on a more of a plant-based diet. And then somebody saying, no, just continue what you're doing. And his approach was more about protecting the endothelial health. And then once I got my scan done, I was like, okay, you know what? I feel really good about this. I can continue on my lifestyle and just continue to eat healthy and whole food. So, you're always weighing the pros and cons of any intervention, but I think getting these tests done is just a helpful part of you having peace of mind of making important decisions in your life.
Yeah. And we actually, a lot of patients ask me, when I go into clinics, I like to talk to people, ask them why they're there, and they ask me what else to do. And I believe, particularly for men, but also women in their 40s or 50s, if they haven't, it's worth doing, for example, a calcium score, just to understand if they have a genetic predisposition for calcification.
Have you heard of the Clearly scan?
Yeah, absolutely. And we have people that do Clearly and Prenuvo together.
I find that just regular CT scan, it's like almost like, I'm not saying it's not worth it, right? Because obviously it's still recommended and doctors mention it. But generally, if you're pretty healthy, like if you, like a lot of listeners on this podcast, like you're not smoking, you're not like a binge drinker, you're not severely overweight, you're going to score 0, but it doesn't tell you anything.
Yeah.
But a lot of people, it gives them a false hope, from my understanding, right? I'm not a physician, but just talking to all these cardiologists, but you really want to know about soft plaque. And you could actually have a shit ton of soft plaque, but end up having a 0 or a 1 on your calcium score. That's why, like, again, I have no affiliation with Clearly. I'm just like, it gave me a lot of peace of mind for my heart health. And that's why I ended up doing it and sharing the results with people. And actually with Prenuvo, everybody's always worried. Like, I came in, I'm like, look, I'm doing everything healthy. I minimize my environmental exposure. My heavy metals reports on all my labs and I'm doing with all my functional docs are great. I give good metabolic health, but shit, do I have prostate cancer or something like that I need to pay attention to? And it was nice that I found out that I didn't, have any of those things.
Well, I think the way I think about it is your health really is a function of 3 things: how you live your life, your genetics, and luck.
Can I pause you on genetics, right? The way we always talk about genetics on this podcast and the different experts that come is that genetics may load the gun, but lifestyle pulls the trigger, right? So your genetics, in a way, because our lifestyles are so out of whack, even now we have, top figures in public health here in America going on 60 Minutes and saying that, hey, obesity is genetic. And when they explain their version of what they're saying, they're really talking about epigenetics, that their lifestyle is activating these things. And so I'm not saying that genetics don't play a role, but how many chronic diseases are purely genetic related? My estimation that I've heard from individuals is like less than 5%.
Yeah, although I think what you're saying is factually correct. It's a semantic difference that matters, but in real life, oftentimes at the end of the day, this is about people understanding what's going on under the skin. And I'll give you a couple of examples.
Yeah, please.
So we almost always diagnose a spine issue with everyone that comes in. Everyone has a slip disc or something going on with them. And particularly amongst younger people today that are spending a lot of time in front of computers or they're looking at phones, we're seeing degeneration of the spine that sort of is running oftentimes 10 to 15 years ahead of where they should be given their biological age.
Yeah.
Now, the question might be, they're still asymptomatic. They feel no pain. And whether or not they're going to feel pain, oftentimes, of course, is a function of the progression of that disease process, but also maybe a function of just how narrow their spinal canal is. And there are people that have congenitally narrow spinal canals for which slip disc, a moderate or severe slip disc, is going to be debilitating to them. And there are other people where we see very severe disc slippage, but they have a very wide spinal canal and they may never be symptomatic. This may never affect their quality of life. And you were born with a wide or narrow spinal canal. So really the genetics does matter. I have a friend of mine that came in, a friend of mine who came in who was a police officer in Los Angeles, and he's around 60, but he looks like he's 40. He's a very fit guy of Mediterranean heritage. And he came in and he did a scan with us and he asked me about, what else should I do? I said, well, go and get a calcium score. And he got a calcium score off the charts. And this is someone who drives through LA traffic with one of those percussion guns hitting his neck to make himself feel better. And, they went and did an ultrasound of his carotid arteries and he had quite a lot of calcification there. So he was like a few hits away from, potentially giving himself a stroke. And he had no idea. And he's a fit person that works out all the time.
Yeah.
So I do believe that genetics matter. That doesn't mean that you can't influence the outcome with your lifestyle. But we all have a certain sort of starting baseline. Interplay. Yeah. And if you don't know where you are on that genetic spectrum, then you don't really know what type of lifestyle interventions and with what seriousness or severity you should be pursuing in order to achieve the outcome that you want.
I would love to go to my scan for a second. So Tessa, if you could scroll down, what's cool about here on the right, I'm logged into my Prenuvo account. On the right-hand side, this medical images and report is kind of walking you through sort of slice by slice by body. So this image, for those that are looking at YouTube and for listening on the podcast, we'll kind of describe it. Just describe what that image is that's there that we're taking a look at.
Well, these are all the images that we took in that 1 hour that you're inside the machine.
You're showing the inside of my body.
Absolutely. And we're rotating through a bunch of different images. Wow, it's hard to annotate as they go. But here we're looking for hardness in the body. This one as well. And this is one of the primary techniques we use to look for cancer.
Yep.
Here we're looking at your prostate. There you go.
And the way that you guys divide these images up in your findings, and of course you have like a team of, I believe, like nurse practitioners that basically hop on the phone with you afterwards.
Mm-hmm.
So you have your nervous system, respiratory system, circulatory system, endocrine system, urinary system, reproductive system, digestive system, and the musculoskeletal system. So those are the sort of systems that you've identified in the body. And what you do is you walk people through how many findings, and you categorize those findings. Can you explain how you categorize those findings?
Yeah, and this is it's a work in progress for us. So we've been doing this now for 13 years, and when we started doing these scans, really no one was using MRI to screen for cancer and disease. So we've sort of had to build a risk stratification approach for categorizing anything that we see in the body in the context of screening. So typically in the context of someone who is asymptomatic. And so as we go through every organ of the body and every condition that we look for, if we see something, we categorize it low, medium, high. And typically low or informational is just something that you should be aware of. Sometimes we'll image patients and they'll realize they won't realize they only have one kidney, or they have a horseshoe kidney. That's where when we're a fetus, our kidney, we only have one sort of organ that's fused and then it separates into two kidneys. And sometimes in about 1 in 300 people, that doesn't happen.
Wow.
And so there's these informational findings that are useful to know. They sometimes affect your risk for certain diseases. Oftentimes they don't. And then medium oftentimes are things that we just want to follow over time. And then there are what we call high sort of red findings, which are things often that require a follow-up test or additional labs or clinicals just to get closer to a diagnosis about what's going on.
Yeah, there's an alert. You need to talk to somebody, go deeper on this thing. And
Correct.
That's typically when people get flagged as potentially having cancer. You're not telling them that they have cancer, but you're like, hey, look, these findings, if I understand correctly, are very similar to what we think could be cancerous, a tumor. Go get it checked out. And then you might say, hey, talk to your, doctor to get a referral to an oncology team or do a biopsy or whatever. Is that right?
Yeah. And really this differentiates us from previous approaches here. So previously with CT, you would see a shadow in a liver and you wouldn't know what it was. And most people are used to looking at these things in a diagnostic context, so they have to go and investigate further. Here, the technology we're using makes it a lot easier for us to separate things into benign, don't worry about, and concerning, do something about. And what's left in the middle is a very, very small number of things that typically are just too small to characterize.
Yeah.
And the test is intended not as a one-off, but a test that you would do every year or two. And so those things that are too small to really characterize, but most likely benign, we just follow over time. And there's no greater or no more sensitive test than to compare you against you a year ago.
Sure.
And see what's changed.
So just looking at my findings here, right? I have a few things that have been sort of flagged with sort of moderate findings. One is nervous system, one is respiratory, and one is digestive system. I think the main one, and I had a call with your team, and this is just me commenting on my own findings here. Tessa, if we click on the nervous system one, I believe one of the things that showed up for me was there was some tiny lesions that they found in my brain, which is not, coming with a diagnosis, but were, hey, these lesions, the way that they were explained, are typical in the earliest stages of multiple sclerosis.
Mm-hmm.
It's something you want to watch, you want to pay attention to. I also reviewed with my own practitioner team, and they said, look, there could be a combination of reasons that you could have had these, and these may not be recent. They could have been something that's been there for a while. Yes, definitely pay attention. Obviously, in my instance, we've had some of the world's top experts on MS and multiple sclerosis, like Dr. Terry Walls. And I live a lifestyle that's very much in alignment with, a lot of the findings that she's seen to help you sort of be in a place where you're avoiding, a chronic diagnosis of multiple sclerosis. But that was really interesting to me, and there was a whole list of things that was presented to me by my functional medicine team that I showed the scan to that said, hey, this could have come from some sort of, MS is ultimately an autoimmune disease.
Correct. Yeah.
And in our world of functional and integrative medicine, usually autoimmune diseases come with some sense of leaky gut, gut permeability, intestinal permeability is the first sign of an autoimmune disease coming, whether it's a Hashimoto's, whether it's a MS ultimately, or whatever it might be. So there could have been early damage that was done from the time that you were dealing with severe sort of intestinal permeability, being on antibiotics and other things like that at a stage in time in my life. It could have come from, environmental toxin exposure. But again, like your own team said, okay, great. Pay attention to it. I don't have any symptoms that are there, but it really brings up this larger point. I had a friend just literally the other week who called me up and said that, hey, I got diagnosed with multiple sclerosis. This is a young woman. She's in her 45 years old. How she found out is that she ended up going to the emergency room, Stein Eye Center here in UCLA, because she was losing vision in one of her eyes and was like freaking out. What the hell is going on? We have an amazing emergency urgent care at UCLA for eye health. She went in and they did a bunch of tests and they said, listen, this seems like it's like the earliest stages of MS. You got to go to this doctor, and then ultimately got diagnosed with, MS. And obviously now is trying to unpack it and everything with the diagnosis. For me here, nobody wants to see that you have a lesion in your brain, even if they're tiny, and it's something to pay attention to. But yet for me, I'm the type of guy which is like, knowledge is power. Okay, cool. Let me know about this. And in combination with all the other things that I've learned from experts on here, it might even have me double down more on some of the preventative things that I personally feel and have learned from my clinical team that would keep me away from, ultimately getting, MS. Anything you want to comment on that?
Yeah, I think, a few things. First of all, I think it speaks a little bit to, again, this very reactive healthcare system that we have. And when you think about these diagnoses, your mind immediately goes to a pretty dark place. MS actually is I think about 1 in 1,000 people on average during their lifetimes will have MS, and MS has different severities, obviously, as I'm sure has been explained. But here we're picking things up potentially early enough that, again, there's a lot that you can do to manage the condition and hopefully do so potentially without involving medication and more lifestyle related changes. MS is a tricky one. It's, of course, as you look to see things a lot earlier, MS is a clinical diagnosis, so there are other things that can cause demyelination, as I'm sure has been explained.
Like chronic mold exposure for some people.
Correct, or lupus or Lyme disease, or there's a number of these autoinflammatory diseases. Also in older patients, just vascular disease can sometimes mimic MS. So we're seeing, obviously, as you start imaging patients earlier and earlier, there are sort of two consequences. One, which I think is very positive, is you get early insight into what might be a potential underlying disease process at a time when you can do more about it. You have more options. The second also is you start to see things that might also have differential diagnoses. And how do you handle that is that you continue to monitor over time and see if this is a process that's an active process, or, as you mentioned, it might have been something that you were born with, or it might be a very stable condition that therefore is not classic for MS.
Yeah. The family members that I've told to get this test done, and one of my friends, I always let them know, like, look, you're going to find something, right? Do you have any data on what percentage of people have no findings at all?
I know we have data. There is some data on MS that I remember reading, which is now that we're doing a lot more, we're diagnosing a lot more. We're identifying it a lot earlier with imaging, that about 5 to 10% of these cases are another disease that's mimicking MS. So it's not a perfect test, and that's why you follow over time. And
what I meant more so is that, like, look, everybody's going to have something, some structural components, some this, especially the older you get.
Yeah.
That we know that obviously there's this whole approach and vision of aging itself as some version of a disease, right?
Yeah.
And so naturally certain things are going to come with it. So I always tell people, your team has its own version too. Like, look, don't freak out. It's not about getting sort of overwhelmed by these things. That being said, like, I do feel my friends that have or have sought out people that are on the sort of medicine 3.0 train, that are used to saying, if you go to your regular doctor and you say, hey, look, I found this finding that's there, right? And they don't know anything about the latest in MS and some of the latest clinical trials that are happening and some of the early, evidence that we have of sort of stopping it and even potentially, putting some of the worst type of MS, like progressive MS, which Dr. Terry Walls has shown with her, studies. They're early. If they don't know about that, I find that people get very bad advice, and that advice is, okay, just wait and see, and let's wait till this gets worse off.
Yeah.
Right. And that's where I find that I've read all about, where people are very excited about, your company and the test. I've also read the backlash that's there.
Yeah.
And we'll get a chance to talk about it. But I find that the backlash, or people, there's a doctor that I really love and respect. His name is Dr. Vinay Prasad. And he had written, because I think like Kim Kardashian did this super viral post and was talking about Prenuvo and why she recommends people do it. And I saw all these practitioners come out of the woodworks who are more in this sort of medicine 2.0 camp, that if it's not complete clinical evidence behind something, then we're like wasting their time and we're putting all these patients on sort of a rat race of trying to figure it out. But those are people that I find that are not aware that there's so much that can be done. And this is even more of a reason why I say, if you get this scan done, which I hope a lot of people do, make sure you're working with a team that is at least in the direction of being open-minded to medicine 3.0, because for every single one of these major areas, there is already published evidence that is emerging that is cost benefit analysis. There's going to be no harm to doing it. And they're often lifestyle interventions, radically improving your sleep, radically getting away from certain food intolerances, or discovering if you have celiac or certain autoimmune triggers with foods, consistently exercising and improving your muscle mass. There's so many things that you can do. But if your regular doctor is just going to Google, or look up, MS doesn't have any cure. So there's nothing that we can do until you have a diagnosis, then we'll treat it at that time. And I find that is very infuriating. I mean, you guys are doing your part, but then the team that they're being sent to is not being told about, or the doctors they have are not being, giving them any kind of hope that there's things that they can do today about it.
Yeah, I think there's really, to unpack it, there's two assumptions here that we're challenging. The first assumption is an assumption that physicians have, which is arming patients with information about their health is dangerous. And the second one is patients have an assumption that the physicians really understand what's going on and are going to do a great job helping them look after their health. And on the first one, when we started doing these scans, in fact, we sat down. So the radiologist sat down and spoke to every single patient immediately after the scan, and we went through the results straight away. And oftentimes these were patients that might have had indeterminate symptoms, and they really wanted to understand what was going on with their bodies. And I myself got involved 4 or 5 years ago, and I remember sitting in some of these consults. And it was incredible at the end of them. Oftentimes the patient would get up and hug the radiologist and say, for the first time, I feel like I really understand what's going on with my bodies. And so this opinion, this sort of anecdotal opinion that you hear sometimes from physicians, we've never seen this play out. A patient armed with knowledge feels more in control, is happier, and is just relieved that someone's really telling them what's going on, and gives them agency to sort of decide what to do about their health. So that assumption, I think clinically over 13 years now, we've completely debunked.
Yeah, the assumption that people have that's like, don't give the patient too much information.
Because they'll freak out or they'll do crazy stuff.
Which, by the way, I don't know if you know a little bit of the history that's here, but the standard of care in the United States in the 50s was left up to the doctor to determine whether or not you tell a patient that they have cancer in the first place. Because back then, the approach was that some patients, and in particular, they believed that women would basically become depressed, psychotic, or something, suicidal even, if they found out that they had cancer. So many doctors, in the earliest of sort of our approach of diagnosing and finding cancer, they would determine to say, hey, I'm not going to tell this patient had that because we can't do anything about it in the first place. It's only going to give them bad information, and then just let them live their life because they're going to do better off that way. And now we can look at that and say, like, actually, that's pretty up, right? To not be able to tell, right?
Yeah.
So, but I feel for people who just believe that there's no preventative approaches and are not on the emerging science, the web, the medicine. I keep on wanting to say web 3.0, medicine 3.0, which a lot of the functional medicine world is very well equipped on. That no, there's actually a ton of things. And they're now, just like when it comes to Alzheimer's, we've had some of the top experts in the world on Alzheimer's on this podcast. They're like, these are the tests that I want to do to look at pre-Alzheimer's. Let's not wait till you have a diagnosis.
Yeah.
And they're not just brain scans. They're your metabolic health. They're your fasting insulin. They're your visceral fat that's inside of the body. And like that, just like we know that pre-diabetes is an issue that affects, hundreds of millions of people around the globe.
Yeah.
You don't have to wait till you get diabetes. You can actually start treating it earlier. And that your fasting glucose is one of the biggest indicators of pre-diabetes. There's a ton of things, like there's pre-MS, there's pre-cancer, there's all these things that we're getting better and better at, until one day you guys come up with a test where we can just scan on our iPhone and we figure out everything that's wrong with us. So my heart goes out to people like Dr. Vinay Prasad, who I really appreciate, that are saying these tests are a waste of time, because I can see it through their lens that most people do not have access to even knowing what to do with that. But that's how everything starts. Most people didn't have access to running water, right? Most people didn't have access to indoor plumbing. So it doesn't mean that we still can't make progress on those things. Most people didn't have access to automobiles, right?
Yeah.
But we still have to get this information out, and it gets better over a period of time. And that's the positive side of capitalism, I feel.
Well, and how does it start? It starts with patients really understanding what's going on, and then they can really advocate for themselves in this health system. So if we find something and they have a physician that doesn't really care much for it or doesn't want to deal with it, they can then go somewhere else. And they're not able to do that if they don't have access to their own findings or they don't have access to their own images. So that for us has always been fundamental to the philosophy of the company, is that this is about equipping you with knowledge, and no one is going to be more interested in taking care of your health than you are. And we've just seen so many cases where we have contacted patients after they've done a scan, if we see something concerning, and they won't have been able to see their physician for months, and we'll refer them to other physicians that will take these things more seriously. We did a review at one point of a patient who we found a 10 millimeter aneurysm. This is a huge aneurysm that is very, very likely to rupture. And we called the patient. Thank God they answered the phone, and we said, well, what happened there? And they said, I went to my doctor, and the doctor said, everyone has aneurysms, don't worry about it.
Wow.
And so this is not to
find a new doctor.
Yeah, this is not to throw physicians as a category under the bus, but physicians, just like any other profession, there are good ones and bad ones. And if you have the knowledge and you have some really clear direction, which is what we provide patients, then you're better able to assess whether you're getting the care that you need.
Is this test just for rich people?
The answer is no. The mistake that people make here is that this is a test for the worried well, so the Fitbit wearing Silicon Valley types. Mm-hmm. The two biggest categories of people that come in for an exam are patients that have had cancer or have a strong family history of cancer, and they really want clarity about what's going on with their health, or patients that have symptoms, so indeterminate symptoms that the health system, they don't feel is addressing fast enough.
Yeah.
And these are people, all of us have a right to good health. All of us care about our health, and people are willing to take sort of things into their own hands if that means that they can get treated faster or more effectively.
The cancer really is still, I know there's a lot of things that you guys have told me that the test is great at. Still, for me, primarily, it's like anytime I feel somebody is worried about that, has a history, maybe is at a particular age, the cancer component is really, to me, like the best part of the test, because I feel like it's one of those things you do not want to find out much later. Not that everybody, you already gave all the disclaimers and everything that, you can only find up to a certain level. You can only do at that level. You got to work with your doctor or physician. But that to me is huge, because outside of this, the only other innovation that I've seen in the cancer space, when it's not perfect, is there's blood biopsies.
Correct. Yeah.
And the problem with blood biopsies like Grails and the other ones that are out there is that great, they're interesting, but they're so sensitive. And you really have to work with the physician that knows what they're doing. And there's so few physicians that are out there in the interpretation. And actually, a lot of people that have tested positive on a blood biopsy because maybe their physicians order it, I know a lot of them that have actually gone and done your scan to actually get a better sense of where in the body is this cancer. Do you have any comment about blood biopsies?
Yeah, actually, my experience has been different. So these blood biopsies are computational tests. And so what they tend to do is set the specificity very high. So they set those tests at a 99% specificity, and that actually makes them not very sensitive for a stage 1 cancer.
Interesting.
And there was a study, I believe, amongst a group of firefighters a few months ago where I don't know which liquid biopsy test it was that they did, but there were quite a number of cancers that were being missed on those liquid biopsies. And so in some ways, liquid biopsy is a more specific test, but less sensitive for stage 1 cancer. Techniques like Prenuvo are much more sensitive, but still sometimes requires follow-up to confirm a diagnosis, so perhaps a little bit less specific. And those two tests, therefore, to some extent, can complement each other. And that's why we do see people that are doing liquid biopsy and then also doing Prenuvo imaging. And certainly, if there's a positive result, before you, at any rate, you'll need to do some imaging to identify the organ of origin and where it is on stage, and a Prenuvo exam is really helpful for that too.
I want to go back to my findings for a second here and just pull up another one. Another one that showed up as a moderate finding for me was my digestive system. So papillary mucosa.
IBMN.
Yeah. So can you explain what this is?
So this is just a small cyst in the pancreas.
Yeah.
We see them very commonly in a lot of patients.
And there's actually an image of it over there. There's my pancreas. Looks pretty good.
Yeah. So that's, in fact, there's the little wispy line off to the right is your pancreatic duct. And there we do a diagnostic sequence called a MRCP. So this is a very fluid sensitive sequence that can look at that little duct that runs through the middle of the pancreas. You can think of the pancreas as a very ugly banana. And that little thing that runs down the middle of the banana, that's the pancreatic duct. And what we want to see is to make sure that that's clear, because pancreatic cancer, what it tends to do is it blocks that duct. So here we have a little small cyst. It's a fluid-filled lesion. Most often, these are benign. We monitor them over time. And we see cysts everywhere. These little internal pimples, you can get them in your livers, in kidneys, obviously in the pancreas. We see sometimes in the brain, and they're benign, and at any rate, we can track over time to see whether they evolve into something else.
Does the machine able to pick up if women are suffering from polycystic ovarian syndrome? Can it pick up that?
Yeah, we do.
It can.
Yeah.
Okay.
Yeah.
That's another thing that we've done a lot of episodes on, and that is a big problem for a lot of women, especially in their prime fertility years. It's one of the top causes that can contribute to infertility. It can cause a lot of, terrible period pains, other things like that. We've done a bunch of episodes, but yeah, that's very interesting.
No, we've seen, and ovarian cancer actually is one of the cancers that we, I would not say diagnose frequently, but it's definitely it's a life-saving diagnosis, because that tends to be a cancer that is caught once it has kind of burst and spread to other parts of the abdominal cavity. So there's no screening test for ovarian cancer. We're able to visualize the ovaries very, very clearly with MRI. In patients that are postmenopausal, we hope to see them disappear completely. But for people that are premenopausal, we can often, the image quality is so good, we can tell which follicle is likely to be the dominant follicle in your next cycle. We can count follicles potentially. And we can start seeing these cystic conditions, and not only see them in the ovaries, but also look for the more concerning clinical signs of what we call septations and areas of where we might see solid masses. Yeah.
I think there was one more other moderate finding. It was my respiratory system, and this was sinus nasal polyp.
Oh, look at that.
So we detected a little lesion, which is suspicious of a polyp. The polyp is located in your left sinus. is measured and it gives the measurements. You should discuss it. Yeah. So any thoughts on this big picture? Just another sort of polyp, cyst in the body. There's multiple reasons these could happen.
If you're asymptomatic, it's just another unique feature of your body. And sometimes that's important information to know. We'll often find people that have chronic sinusitis by looking at the sinuses, and they won't realize that, or it might manifest as migraines, for example.
Yeah. The way that it was explained to me by my physician was, in my history, in functional medicine, they do this whole like deep history with you. And as part of that, they're asking you literally starting from the beginning, you know, how were you born? Were you born naturally? Were you born via cesarean section? You know, were you this, that, what exposure to bacteria did you have?
Yeah.
So when I was young, I had a lot of sinus issues, and my family didn't know it at the time, but I grew up vegetarian, and dairy was a big part of my diet, and commercial sort of westernized dairy was just not working for me. I wasn't lactose intolerant, but I would have dairy and I would have chronic sinus issues, and this could have been inflammation that was there, a polyp, a protective sort of thing that happened in the body. Once I, in particular, got off of commercial dairy, which happened when I was in high school, I never had those issues again.
Those attacks again.
And I was in a good position, and I didn't have to take regular antibiotics and other stuff. I've told my story multiple times in this podcast. So this could have been left over from that time period because I don't have any symptoms right now. But again, something to just pay attention to in the future.
And my understanding is these things can come and go. So you might come in next year and it's not there. What we like to do is we like to do a very comprehensive cataloging of what we see. And I'll give you an example. My wife, we scanned her, and she has a benign but quite large lesion in her liver, and we know it's benign because of the different collection of images that we're able to take. We know it's filled with blood and not solid, and therefore we know that this is a hemangioma. It's like sort of an internal Gorbachev-like birthmark that we can get inside the body, and it's there from the moment you're born, and it'll be there when you die. But it looks big. It's the size of a golf ball. And she also just happens to have some liver metrics that are a little bit unusual. And in another context, that might look suspicious for cancer. And then you might end up getting a biopsy. And we know, because we've cataloged it and we know that it's benign, this is really important information that she has then to go out and be able to provide to the health system should this ever be questioned at some point in the future.
Talk about the cost of the test. And also, is there ever a vision of this being covered by insurance?
Yeah. So before we started doing these scans, the closest thing to this would be a scan that is sometimes done at tertiary institutions for people who unfortunately have this certain cancer predisposition syndromes. And often those might cost $25,000 to $50,000. So already we sort of reduced the cost by an order of magnitude. Even at our current cost, you have 78 organs in your body by last count, according to Wikipedia. And so the cost of our scan is something like $32 per organ. And we believe that over time, we can get the cost of these exams down to something like $500 from where they are today, which is $2,500. So now we're screening every organ in your body for something like $7. There is no other preventive health test anywhere in the world that is as inexpensive as this. And that's one of the often overlooked benefits of screening the entire body in one go is it becomes extremely inexpensive to screen any one organ, and therefore potentially not only a solution that can save lives, but also much, much more cost effective than sort of the piecemeal approach that we have to screening of patients that have high risk of certain conditions.
Do you ever imagine a place where insurance is picking up at least part of the tab?
Yeah, we're already in the process. So we have now 13 years of clinical evidence, and now we're in the process of kicking off both prospective clinical trials and retrospective clinical trials to really collect the sort of evidence that's required to engage in dialogue with insurance companies and healthcare systems so that one day this becomes standard of care.
It feels to me like just based on the cancer component alone, just knowing how expensive it is to treat cancer, having had multiple family members, unfortunately, that have gone through cancer in the past, it seems like that alone is like a no-brainer for the insurance companies.
Yeah, the stats on cancer are crazy. So we spend $150 billion on cancer medications alone in the US. And most of those are therapies for advanced cancer. We sort of estimated internally that were we to use an abridged technique that just looked for cancer in the torso and to screen the entire population in the US, we could probably do that for 60 or 70 billion. So on a pure financial basis, this is a win for the health system. And then, of course, on top of that, and more importantly, would have the potential to save millions of lives. So I think that's, as a company, really the mission for Prenuvo is to work towards that goal where there is coverage for everyone, and this becomes standard of care in a healthcare system that is completely reinvented to be much more preventative.
Yeah. On top of that, obviously, there's a whole discussion about just healthcare access in the U.S. in general, and not having universal healthcare, which we chatted a little bit on the podcast. What's interesting, I got to look back at the paper, but they brought this up on one of my favorite podcasts. It's called Breaking Points, and it was comparing wealthier individuals that have, good insurance in the United States comparatively to well-off individuals in Europe. And even when you compare, those two sort of population sets that have really great healthcare coverage, the ones in Europe had general better health outcomes. Obviously, there's so much that goes into it: society, food exposure, et cetera, other stuff. But they isolated for a few different things, and they were just showing that when you have access to, this universal healthcare, those populations that have access, even when you sort of equate for income and a few other components, that generally people having access to healthcare is going to lead to a healthier population. Obviously, there's a whole bunch of problems. My friends that are in the NIH in London, in the UK, in Canada, there's a lot of problems because everybody's getting sicker everywhere in the world, and none of these healthcare systems, and this is where actually I don't think there's enough criticism on the universal model that like Canada and England have and a lot in Europe. It's very hard to get any kind of preventative component. It's like you're prioritized to the top of the line if something is urgent right now. If it's not, you got to wait years sometimes to do it. So I think there's a bigger discussion about whether you have universal healthcare or not. We just need an entire system that shifts towards prevention. And I really feel that technology, AI, all the future stuff that are coming is going to be a part of that.
Well, and I think there's no one model that has got anywhere close to the solution. In the US, you have a system that there's no better place in the world if you have an acute problem to be treated than the US. We have fantastic doctors. We are able to utilize cutting edge approaches. This is sort of precision acute medicine system is sort of the envy of most of the world. Then you have other parts of the world where there's perhaps a greater focus on preventive health, but they don't have the depth that the US has for treatment of acute conditions. And I think the answer somewhere is in the middle, which is we're looking for really a preventative but precise system and something that's tailored to the personal needs of every individual. And I think that's the world that we're trying to create.
Does this show me how much visceral fat I have in my body? Are you guys at a level yet where you kind of provide that information to patients?
Not yet. I mean, you can eyeball it, and oftentimes if you have a lot, it's mentioned in the report. But this speaks a little bit to some of the research that we're doing as a company. So we're really, really excited to and are investing a lot of time to understand some of these lifestyle factors and early disease processes of age-related degeneration. That could be brain degeneration, that could be spinal degeneration, liver, kidneys, and so on. In fact, can we peel back the clock on diagnosing disease a lot earlier? And the earlier we can, the easier it is for you to treat and sort of positively affect your health trajectory. It's incredible what we're able to see. I have a team of now 20 people that are actively doing research across every area of the body, developing models that are able to tell us in a much more quantifiable way how your health is tracking. And one of those is visceral fat. And we're in the process of putting that through an FDA regulatory process so that we can present that to patients as part of their reports. Having said that, we've already acquired those images of you. So when you come back the next time, we will be able to tell you how your visceral fat has evolved, how your liver fat has evolved, ideally your pericardial fat, your pancreatic fat, if you have any there. And this, I think, is really the future of health, which is precise, quantifiable metrics of things that we know are highly correlated with age-related degeneration so that you can do something about it.
I'm guessing you had your scan done.
Mm-hmm.
And was there, how did you feel after you getting your own scan done?
Well, I did my scan 5 years ago in that first clinic in Vancouver, Canada. And I was just really looking to understand how I was tracking in my health. I hit my 40s, and I'm a serial entrepreneur. So I work way too hard, do not sleep enough, and really haven't looked after my health, if I'm being totally honest. And so I wanted to take stock. And this exam was, for me, just an incredible experience. I learned more about my health than I had learned my entire life. I learned that I wasn't. Thank God I didn't have any cancer or didn't have any aneurysms. There were some things that I could work on, but I remember this feeling after I did the exam. And I don't know I'm sure you might have some listeners or I don't know if you've been skydiving or something, that feeling of adrenaline you get for a couple of weeks afterwards, where you sort of look out on the world and everything feels a bit more colorful. That was the feeling that I had, that tremendous peace of mind to not really have to worry about what was going on inside my skin. And I'm not a hypochondriac, so this was not sort of a panacea for a problem I had. It's just, I think as a normal person, I had these very normal questions that I wanted to have answered about my health. And from that moment on, it really felt like this was a mission that I wanted to dedicate my life to, which is to find ways to continue to prove out this technology, to find ways to bring it to as many people as possible, to bring the cost down, and eventually through Prenuvo and other tests, like Clearly, present a alternate model for healthcare that we think can be transformative and, possibly, of course, also less expensive than our $3.5 trillion health system that we have in the US.
Yeah, nothing is more expensive than treating disease at a later stage. I want to say from my side, we went through my findings and everything. It's really like knowing that nothing major on the major things that you guys look at, and we talked about the areas that you do look at, the areas you don't, that there's nothing that is showing up in the test for what you do. I will combine that with my normal sort of metabolic labs, some of my advanced, genetic testing, other things. And then with all that information, you get kind of a complete sense of like, okay, great. I'm doing good. or here's the areas that I want to improve on. And so this was really helpful to know that, I didn't have anything major going on that had to be addressed immediately.
Yeah. And by the way, I'm sort of living proof that this is not just for people that have six packs and, are into the latest in preventive health. I'm a very normal person. I have very normal health. I look after myself in, a very normal way, shall we say. But just, I feel more comfortable knowing that there's nothing going on under the skin. And I know that if there was, I would want to know about it so that I could make those lifestyle adjustments earlier rather than later. So, so we have a lot of entrepreneurs or business owners or people that, just want to have that sort of peace of mind so that they continue to do great things for the country.
Probably because people will see it on the screen. I'll just mention it. There was another finding that was in my reproductive system, which was the one we didn't go over. It was basically saying that my prostate is smaller than the average. My prostate is 21 ml, and the normal prostate on average, and I know I'm definitely like a leaner guy, but why would this come up as something to pay attention to? It's just comparison.
Actually, this is just an informational finding for you. So we actually want the prostate to be small.
Yeah. So I thought it was a good thing.
It is a good thing, actually. Yeah. Prostate is one of those organs where you actually want it smaller, not bigger. And what we tend to find as people get older is the prostate grows in size.
Yeah.
And that can grow. And of course, prostate is the most common cancer for men. In fact, the saying goes, most men either die from prostate cancer or with prostate cancer. And by being able to precisely measure the volume of your prostate, we can start to tease apart three conditions that are often confused by other tests, notably the PSA test, which is prostate cancer, which elevates PSA, prostatitis, which is an inflammation of the prostate, which elevates PSA, and something called benign prostate hyperplasia, which is an enlarged prostate, which also increases PSA. So because we're able to more precisely separate those, we can avoid the need for men to go and get biopsies, which is what used to happen when you had an elevated PSA.
We mentioned earlier, you guys had, I think it was Kim Kardashian did a big post about it, right?
Yeah.
Did that break your clinics in good and bad ways?
Well, there's nothing unique about her, to be honest. This is, for us, is a very this is an old-fashioned business. We're a medical company that is hell-bent on providing the best clinical quality screening exam in the world. It's the only thing that we do. We're not an imaging clinic that's trying to do this on the side. We spend 100% of time doing this. We've optimized the experience, the hardware, the software, and so on. And when we provide a great experience, people tell other people about it, and they come in. And the vast majority of patients that we have are coming in through word of mouth. And that includes people like Kim, who heard about us through other folks. In fact, most of the celebrities that have spoken about us have reached out to us because they heard about it through a friend. It's not necessarily through any active outreach from the company. And certainly we don't pay people to promote us because that sort of runs against the ethos of the company. It just so happens that people like Kim have like a massive audience and have this real potential to raise awareness for these new techniques like Prenuvo, and hopefully that's going to lead to lives being saved.
Yeah, there's nothing wrong as a CEO when somebody who has a couple 100 million followers decides to organically talk about you.
But I can tell you, when that happened,
yeah,
we didn't know it was happening.
Yeah.
I was on a plane to New York, actually, to our clinic there, and I just happened to be monitoring Twitter or Instagram, I forget what it was, and I saw this notification pop up that she had posted. And I'm like, okay, here we go. And obviously it raised a tremendous amount of awareness. A lot of people reached out with questions, and we've tried to help as many people as possible. And obviously it's been great for the continued growth of the business.
Yeah. And I think in a good way, if you believe in what you're doing, you're okay with people stress testing what you're up to.
Yeah.
When somebody that big promotes you, obviously you're going to get the good, bad, and ugly from all sides. But if you believe in what you're doing, you're not afraid to have the conversation and dialogue. What were some of the, we brought up some of the stress testing, criticism ideas earlier, but was there any other valuable sort of, I don't want to call it a negative response, but was there any valuable criticism that you guys were hearing? I know you've been doing this for a really long time, so I can't imagine you heard anything new. Maybe the scale was different. But was there any valuable criticism that is really part of a larger dialogue about healthcare and access that came from that incident?
No, I think most physicians are asking what I think is quite an appropriate question, which is, we need more clinical evidence to be able to prove or disprove that these techniques are useful at the level of population health. And my answer to that question is absolutely. But it takes time for this to, it takes time to collect that evidence. Techniques like mammogram, they were in clinical practice in the mid 60s, and they didn't get covered by health insurance until the 90s.
Yeah.
And they got covered because there was evidence from millions of people that actually had done these things in clinical practice, and you were able to therefore collect the quality of clinical evidence that's required to make a decision to cover this at the population level. Now, I hope that this process is faster for us, but I also acknowledge that, and we are very intent on collecting more evidence beyond what we know from our clinical experience. Most of the criticism that we get just relates to folks that don't really necessarily understand the techniques very well. One thing perhaps that's important to stress to your listeners is that these techniques that we use with MRI, MRI is a qualitative imaging modality. It's not a quantitative imaging modality. What do I mean by that? What I mean is, just like you have good surgeons and bad surgeons, the efficacy of a screening technique using MRI is going to depend tremendously on the hardware that's used, tremendously on the images that are taken, on the training of the radiologists, and increasingly on techniques like AI. And any sort of criticism of the space without really understanding what any particular company is doing should be taken just as that. And oftentimes when we receive criticism, my first response is to reach out to the physician and invite them to learn more about it, and learn about how these things are different. And you would be hard pressed to find a physician who has firsthand information about what we're doing that hasn't brought their partner or spouse in and isn't referring appropriate patients in for screening. So education really is an important part of what we need to do to also help provide knowledge to physicians so that we can sort of change hearts and minds.
Yeah, and just even the dialogue, right?
Yeah.
We live in a day and age where everybody wants everything to be ready for everyone. It's actually kind of like a little bit of a messed up, privileged point of view of the world that every single innovation recommendation should be ready for mass adoption. And it's kind of a byproduct of, I personally feel, of a time and day and age that we're living in where we have it really good. We have so many things around us, even though there's plenty of people that are suffering, even though there's so much economic disparity. Yes, there's things that are really wrong, but our expectations are quite high, at least in America, of how things should be ready for everyone. And I think the thing is that innovation is messy sometimes. And so many things, like I'm a big fan of a lot of the work that's being done in the space of psychedelics. And if you understand that this is a movement of individuals that for many years had to operate underground to kind of slowly convince people one by one of the therapeutic approaches of psychedelics like MDMA to have a major impact on PTSD and trauma and other stuff, way better than medications that are out there, you realize there was a small few people that had to fight, even when certain drugs were illegal, to actually get us to a place now where you have members of Congress in a bipartisan way talking about, okay, hey, we need to rethink about the classification of these as drugs and at least open it up to more research and potentially FDA approval. Like everything goes through a battle before it's brought there, and nobody understands that better than the people that are involved in that fight. I'm glad that you guys launched, direct to consumer, because I've seen plenty of companies try to go down the route of waiting for insurance one day, and they don't have enough momentum or data set to convince the gatekeepers. Yeah. And so they never take off the ground, right? They call it like death by clinical trial. You have keep on doing different trials, but you're trying to get some hospital system or some place to approve you. But, at least this is available. This is an option, and not every option is for everybody, but at least this is another option that's on the table for people that want to pursue that option.
Yeah. And we do a lot of education. So every month or two, and if you have listeners that are interested, they should sign up on the website at prenuvo.com. But we do a webinar for consumers where we literally we have a radiologist take people through a study, and we go through someone's body and we have a conversation about what we can see and what we can't see. And we take a lot of questions from consumers that are curious. We do a similar thing every couple of months for physicians, where it's a similar process. We take them through one or two exams, and we have a more clinical discussion about, what we can see and what are the drawbacks and false positives and incidentalomas, and sort of answer some of the questions that physicians who may not be familiar with these techniques have. And slowly but surely, we've now got hundreds of physicians that are referring us patients, and thousands of consumers that are looking for forward-thinking physicians to work with to help them run their health.
Yeah. Andrew, this has been great. Thank you so much for coming on the podcast. I think your team set up a little code for people. Mm-hmm. And just to be clear, I'm always about disclosing everything. I don't get any kind of compensation for this code or anything like that. It's just a code that gives people a discount if they want to do it. I think it's $300 off. And it's, we'll put it in the show notes, but it's prenuvo.com/Dhru, DHRU. And that'll give people $300 off the $2,500 price. Tessa, can we just see if that's active for the people that are on YouTube? We could just see if that link comes up. And okay, great. Perfect. The discount code is applied. Dhru Purohit cares about you, and so do we. Yes, I care about all my listeners. So yeah, if you feel like this is a test that is something that could be beneficial for you, and that's why we wanted to have you guys on to talk about, the pros and cons of it. And I think especially in early cancer detection, from my, personal thing, I haven't seen many things that are out there that really can find cancer this early in a way that's so specific. This test is great. And we have to keep on fighting the good fight and tell people, to practice all the healthy lifestyle habits to reduce chronic disease. And yes, maybe one day Prenuvo will be part of insurance, and all those things are part of the equation too. But if you can afford it and it can be part of your plan, you can sign up now at prenuvo.com/Dhru. Andrew, thank you for coming on. Any final words?
Yeah, no, I tweet a fair bit about preventive health. So if people want to follow me, I'm Andrew Lacy on Twitter. And of course, if people are interested in learning more and attending one of these webinars that we do routinely, either reach out to us through the website, or they can follow us. They can follow Prenuvo on Instagram or on Twitter, and we give people a lot of notice when these webinars are happening. And we just hope that people, learn as much as they can about some of these new techniques. And if they're right for them, we're really happy to help them on a path to better health.
Amazing. Appreciate you, brother. Thank you for coming on.
No worries. It's been great to be here. Thank you.
Hey, YouTube, if you enjoyed what you just saw, keep watching for more great content on how to improve your brain and your life.
People who I saw, you could tell that they were less irritable, they had less brain fog, they could get along better with their coworkers, their family, and they're coming back and they're improving.